I'd like to begin our final session of the day, Improving Status Quo, Dialysis. First of all, I'd like to introduce my co-moderator, Dr. Ashton Collins. He's Assistant Professor of Medicine here at George Washington University, and he will conduct the question and answer portion of the panel. Along with our speakers, Dr. Rebecca Schmidt, Professor and Chief of the Department of Medicine at West Virginia University, and both a member of AAKP Medical Advisory Board and a former president of the Renal Physicians Association. Dr. Juliana Blum, co-founder of Humacyte, and Dr. Ikenna Okezie, co-founder and CEO of Somatus Incorporated, and Brian Hess, who is a transplant patient and a member of AAKP's advisory board. Dr. Schmidt, I welcome you up to begin.
Well, thank you very much, Richard, and thank you very much, AAKP and GW, for the kind invitation. I have the humbling task of talking about redesigning the status quo or improving the status quo, and with something that I think that is not really that innovative and maybe should be more default than it really is, but what I call incorporating dialysis into our lives rather than vice versa. I am not the chief of the Department of Medicine, thank goodness. That is an error. I was the section chief for the nephrology section for 17 years at West Virginia University. I'm currently an assistant dean there in outreach and community engagement, a big word here today. I've worked in dialysis and in CKD for a long time, and again, Richard already mentioned that I was a past president of the Renal Physicians Association, and I'm on several boards. My clinical focus has really been outreach for the past 26 years and life transitions and improving access to care. And my very important disclosure is that I'm the wife of a transplant patient as well. So I think, we as medical professionals, dialysis companies, policymakers, our quest for improving outcomes and doing the right thing, providing medical care, sometimes we focus on things that maybe aren't really what the patient is focusing on. And our focuses are global and population-based, and the words patient-centered have been used, but really we need to think about it as being person-centered. We are not the person sitting in that dialysis chair. And patients have lots of challenges that they need to deal with when they start dialysis, or even during dialysis if they're on it for any period of time, work schedules, if they're able to work, treatment schedules, medical problems other than their kidney problems, intercurrent illnesses. They have all the same problems that someone without kidney disease has, tests for transplant workup, home and family needs, day-to-day medical problems. All of these are areas of challenge for our patients, and it's something that we have to work with them to help them coordinate as well as their dialysis. So it becomes quite a bit of a balancing act for the patient who is being almost told you need to incorporate dialysis into your life or incorporate your life around dialysis. And really what I try to teach my patients and my team works on is helping patients incorporate dialysis into their life. And the patients are faced with medical appointments, surgical appointments, all sorts of other problems and issues that didn't face them before. They are placed, have to adapt to the fear of maybe life not being as they have ever expected it to be, or certainly not as it was in the past. And things that we can perhaps do to help create a culture that incorporates dialysis into their life as opposed to the opposite is very, very important. Perhaps a flexible treatment time, flexible modality choices, and in our program we use respite treatments and telemedicine visits as well to try to help incorporate dialysis into the patient's lives rather than the other way around. So trying to improve our way of being innovative is using the resources we have. And sometimes that's very difficult, but as I tell the patients, we do the best we can with the resources we have. Our ingenuity is our innovation, and we've tried to revamp our traditional care into several different programs. One is our transitional care program, where we try to provide an experience for the patient that is different than what maybe many of you experienced in starting dialysis, particularly those patients that start dialysis abruptly, to provide an experience that builds relationships and trust, optimizes the informed decision-making that needs to happen so that patients can make a decision about perhaps their modality of dialysis with a comprehensive education. So we are optimizing the opportunity for them to see what is out there and what is going to be best for them, and help them make a good decision about the type of dialysis that they would choose. And obviously, if they are able to have a transplant, and we try to encourage everything that can happen preemptively, because a preemptive transplant is always better than going on dialysis first. We actively assist them with their schedules for their transplant appointments, their access appointments. And one of the benefits of this program we've seen is that we've had a lot more patients choose home dialysis. This program basically serves as a gentle bridge to in-center dialysis. It's a formalized 2-week program that is individualized to the patient's needs. If they work, we try to do it according to their work schedule. We dialyze them on home dialysis machines, the next stage machine, right in the unit, so it exposes the other patients to this modality. We have one-on-one care, and it's something that a lot of patients have chosen to go through. We have a curriculum. The first week is the basics of dialysis. The second is diet and fluid balance, vascular access, importance of adherence to treatments. And in the second week, we talk about the basics of home dialysis, peritoneal and home hemo, patient-to-patient interaction, presentation of equipment, and discussion of modality options which are best for the patient. And usually patients complete this in a couple of weeks, but we've had patients that stay on this program for several more weeks or even months as we prepare them. We had one patient that was was supposed to get a preemptive transplant, had an acute kidney injury, needed to start dialysis, and we essentially kept her in this program until she was able to get her transplant. This is our team. It was started by my colleague, Dr. Beth Pellegrino, and Melissa Glover, one of our longtime home champions. And 7 of the 13 patients that we graduated have gone to dialyze at home, and 1 was transplanted, as I mentioned. So the success factors are the patient's motivation and interest. The patients are really interested in this, and we want to champion this, and we want to encourage them, and they are very engaged. So someone mentioned the definition of patient engagement earlier today, and my idea of patient engagement is that the patient is involved in making decisions and in every aspect of their care. And so this is a bi-directional program where we work with the patient, the family at their availability, and some of it's dependent on the time it takes is dependent on how the patient's capacity for intense interest, intense education. Some people want to learn this slowly, others quickly. So it depends on some of their medical issues that are going on at the time, and we try to tailor it to what's going to work best for that patient. And on the staff side, we have the one-on-one attention, which is very key to the program, and it's a culture of flexibility. So I think one of the biggest challenges is to build that culture that this is not just something that we're doing because it's a program. It's doing this to individualize and work with the specific needs of every specific patient, which are different. So sometimes the barriers that we find to this transitional, to traditional care, the traditional treatment schedules, these offer opportunities to be flexible in our care, and we call this our flexible care program, so to speak. But many of our patients have scheduling conflicts, and they need different types of training. They need time-directed training. They need training at night in order to live their lives. We don't want somebody stopping their job or not doing their other responsibilities because they have to train. We want to train them in the time that's convenient for them. And that may be the training at home at night. They may not have transportation to the unit, so we also will go to their house and train them at home in order to minimize their clinic visits. Sometimes there are issues with care partners, and care partners have scheduling conflicts, and we try to use the electronic communication modalities that we have, such as the patient portals, to work with the families and the patients. And we are very much encouraging proactive solo training for our patients who are able to do this. This was not something that was encouraged in the past years, but we found that it has worked well with the patients who have been interested and tried it, and it has caused me some lack of sleep at night, worrying perhaps about some of the patients. However, this is the patient's choice to do that, and I feel that it's not my position to say you cannot do this just because you're alone. When patients have modality or choice or burnout, sometimes we switch them, and switching modality temporarily has worked well for some of our patients. Some of them require a permanent switch. And again, with patients that have employment conflicts, we have nocturnal dialysis, and some patients we arrange their scheduling around work. And again, this is not so innovative, but it seems to be common sense, and it seems to be, and it works for our patients, and if it makes one patient happier than they otherwise were, that's worth it to me. So just some examples of some of these types of flexible care. We had one patient whose husband died, and then she got married to had another husband, and the husband didn't want to travel, and so he didn't want to drive, and so she was on in-center hemo. He didn't want to drive, so we taught them how to do PD. So she switched for PD. That husband died, and she switched back to in-center training. I'm not saying that much about the death of the husbands, I'm not sure. But I mean, in any event, we were able to switch her modalities just to fit her lifestyle, what was best for her. We had another patient, Mr. B, on this cloud, who started out on in-center, and he then moved to PD, and his wife did his PD. They're like in their 80s, and she did the PD for 4 years, and she, quietly came to me one day. She goes, "I just can't do this anymore." And so we talked to the patient, and he ended up switching back to in-center, and everyone's really happy now. And another patient, we had a young lady who was trained on home hemo, and her mother just didn't really want to do it. And her mother just didn't really tell us the truth in the beginning, that she didn't really want to do it. And we kept trying to figure out how to get her to do it and train her. And so we said, well, we'll train the patient. And the patient's access was in such a place that the patient had short arms, and she couldn't reach it. So we trained her on PD. So, we switched it but we have an access in case she wants to go back to that ever, or her mother wants to do it someday. We had another one, a patient whose wife tragically passed away, suddenly after being a very healthy, well person, very shocking, and the patient is being trained solo now. So there's a lot of situations, and our patients have the same problems that everybody else does, in addition to the fact that they have kidney disease and need some sort of kidney replacement therapy. So, trying to meet their needs with flexible schedules, nighttime training, nighttime dialysis if necessary, solo training, and then respite care are ways to help them incorporate dialysis into their life and not the other way around. Now, respite care is a temporary modality change to in-center for patients who are on either type of home dialysis. And the goals of these are to provide a break to the patient or the caregiver and give them some respite. And with the idea that, you know, short term, the patient's going to go back to the home dialysis care at some point in time. Sometimes patients need a long-term caregiver respite, and we find too that being able to provide this respite, more people go back to home hemo. They don't just stop and give up and never go back to it. So it's proved to be very helpful to a lot of patients and families. And what we do, we introduce this early on and when we're training patients as part of the expectation for the future. It's not wrong to get tired and need a break. And we teach the caregivers and as well as the patients how to recognize when they need respite. And we promote the idea that the requesting respite is expected. We don't want people to think that this is a weakness or that they should be able to just keep going on, but we promote the idea that this is appropriate, expected, and we would think it was weird if they didn't ask us. And then, you know, we can encourage solo dialysis training, and particularly in patients that are working, and those patients who have family members who may be in the household but just may not be interested or willing to perform the dialysis. And that can also give people respite, you know, in a more frequent basis. If they're in the house, maybe one patient does their treatment 1 week and then the caregiver does it the next week. All sorts of scenarios are possible. So the other area that I think is improving the status quo in dialysis, if that's possible, speaking on this topic among all this innovation of the technology and the tests, et cetera, is a little bit more than humbling, but that is the area of telemedicine. And, you know, telehealth, telemedicine, there's a lot of different health services that can be provided using teletechnology. And, you know, telemedicine specifically refers to clinical services that are provided, a clinician providing a medical service that are by a teletechnology. And, you know, one example is a mobile app that lets physicians treat patients remotely or via video chat. The type of telemedicine I do is an actual visit over the television, basically the computer screen. And there are certain types of software that dermatology physicians use to take pictures and send, or have referring physicians take pictures and send to dermatologists. So there's all sorts of different types of telehealth modalities. The advantages of telemedicine are that it's convenient, and particularly for someone like myself, who lives in a rural state, and many of my patients have to travel, or I have to travel. Someone usually has to travel to have a visit, whether it's a dialysis visit or it's a CKD or a transplant clinic visit. Telemedicine makes for a more accessible visit, and we can see the patients more often. It saves on travel for patients. A couple of years ago, my rural clinic system, we calculated that we had seen 50,000 off-site outreach visits, which saved patients 6.5 million miles of travel. So it saved the patients the travel, but it didn't save us the travel. So someone's got to travel, and in states like West Virginia, and telemedicine is a way to reduce some of this. It allows, as I said, more frequent interactions with physicians, and also we're using it with our transitional care team to try to coordinate care better between the different specialties and on hospital discharge. Some of the difficulties and disadvantages of telemedicine is that the rules and regulations are a little bit daunting to some extent, although these are improving, and there are more and more legislative efforts ongoing federally that currently particularly relate to the opioid crisis and MAT, but there are other there's a lot of efforts in different states to make this easier. And although the states, it's kind of, if you've seen one state's program, Medicaid program, and laws relative to telemedicine, you've seen one state's laws and relative to telemedicine. But there are, there are things that are happening that are making it a lot easier. There's things with licensing that states are coming together and having a compact licensing program so that it's easier to do the telemedicine across state lines. The HIPAA, which is federal, is still there, but different states have different ways of making sure that things are security of patient information is protected. And so there's a lot happening on this front. The other difficulties, it requires some technical equipment, and in some rural areas, for instance, there's no broadband, and there's not, there's no way, you don't have the connectivity. So these are things that are coming and are getting moving forward. They're required, you need to have resources and staffing on both ends of the spectrum, both that end and my end and the patient's end. And it does reduce your personal interaction. I've had one patient says, I don't want to see Dr. Schmidt on that telemedicine thing anymore because then I don't get a hug. So, there are some downsides to it, but for the most part, it's proved to be very helpful and allowed my group anyway to see patients that we otherwise would not have seen because they couldn't travel and we didn't go that far away. Some of the programs in the country, there's for kidney patients, one is in the Zuni Comprehensive Health Clinic in New Mexico. There's a University of Alabama nephrologist that does rural Alabama home dialysis patients by telemedicine. And then there's some institutional, inpatient dialysis care consultation can be achieved through telemedicine in rural community hospitals. There are companies that do teledialysis in smaller hospitals so that patients would not otherwise, who could otherwise be admitted there, don't have to travel to a tertiary care center. For instance, in my neck of the woods, everyone travels to my hospital, even though they live 3 hours away, because they may not need to be at the hospital for anything but dialysis, but they need dialysis. So we're working to try to look into how can we provide dialysis, teledialysis at some of the local hospitals in the rural areas. And then there's a pilot program for home dialysis patients in Georgia that is just starting out. And then we do chronic kidney disease and transplant clinic by telemedicine in West Virginia. And this is a picture of I'm sitting in my office, so I have two screens. One has the medical record, one has the patient, and the resolution is so good. If I wore makeup, I could do it in the screen. It's so good. You can see every little thing. You can't just like wear your pajamas or something in here, because it's really, and you need to look good because they can see you really well. But you can see how I'm in Morgantown. If I'm in Morgantown on the top circle, and I can see those patients in Oakland, Maryland, and Elkins, and we have setups for Moorfield and Kaiser, West Virginia as well. So what are some of the questions about this? Is it possible for outpatient dialysis patients to do their telemedicine, their clinics by telemedicine? And this is something fairly new. Outpatient home dialysis patients will be allowed to have teledialysis visits with their physician at their home or at their dialysis unit. Now, this is home dialysis patients only. This was approved, legislatively mandated starting in January. And it is not yet the case for in-center patients, but for home dialysis patients, and if you're out there, that may be something that your physician or your dialysis unit will be looking to do. 1 out of every 3 can be done this way. Face-to-face visits are still needed for the other visits. What services are needed and what can be appropriately provided by telemedicine? Some types of discussion and some things that you want to talk to the patient, or if you need to thoroughly examine the patient a particular time, this may not be a good thing for telemedicine. You need to have staff and resources engaged at the different sites. And as I mentioned before, you need to have equipment and technology that are available to use the telemedicine at a given site. And when we're thinking about whether or not to engage telemedicine and what's useful and meaningful, really what is meaningful to patients? And in my neck of the woods, what is meaningful to patients is not driving to Morgantown, West Virginia, or not driving 3 hours to see the nephrologist. They want to be able to communicate and talk to me not just by phone, but having the telemedicine availability makes it a lot easier for everybody. So inpatient use for telemedicine is growing, particularly in rural hospitals, and as I mentioned, there's some teledialysis that can occur in a rural hospital, which would help allow a patient not to have to be transferred to a tertiary care center that may be distant to their house. There are several scenarios about how home dialysis patients can be seen by teledialysis. One scenario would be that the patient is at home, and the doctor, the nephrologist, and the dialysis team are at the dialysis unit, and so they use the telemedicine capabilities that way to connect at the patient's home. There are some stethoscopes that are out there that the patient can use to listen to themselves. I think that's a little bit difficult, to listen to myself when I'm think I might be sick. I try to listen to myself with my own stethoscope, and I, of course, never hear anything really that well. So I don't know how well that would work, but that is one scenario. Another scenario would be where the patient lives next to the dialysis unit and the doctor lives far away. So the patient and the dialysis team are at the dialysis unit, and the doctor is at their office or their clinic. And then finally, in situations where both the physician and the patient live distant to the dialysis unit and to each other, the physician can do this in their office with the patient at home. So there's a variety of scenarios that may be able to be engaged to move telemedicine forward as a way to help improve our care of patients. And with that, I'll stop. I think it's really important that we help our patients incorporate dialysis into their life and not the other way around. And if there are any questions, I'll take them at the end, I guess. Thank you very much.
Hello and good afternoon. I would like to take a quick moment just to thank the AAKP and GWU for inviting me here today. My talk is going to be a little bit different than what you've seen already. I'm going to talk about innovation and how it might impact dialysis patients' lives for the better. My name is Juliana Blum, and I am one of the co-founders of Humacyte, and we are bringing bioengineered blood vessels, hopefully to patients in need in many different vascular applications. But our initial indication that we've been researching for the past 7 to 8 years has been for dialysis access using one of our engineered blood vessels as a conduit for dialysis. Humacyte was founded back in 2005, so for about 15 years now, we've been working to bring these tissue-engineered products to market. I will tell you that it was 15 years before we started Humacyte that we were also working on this in the academic setting. So by the time we're able to take this new innovative technology to patients in need, it will be almost 30 years in total. So let me tell you a little bit about the technology and how we make our tissue-engineered vessels. It begins with the gift of donation. We work with many OPO groups or organ procurement organizations throughout the U.S. to recover distal thoracic aorta. So a segment of a donor's aorta is sent to one of our cell processing facilities, and cells are recovered from that tissue. Those cells are then thoroughly screened and found to be safe and suitable for use, and we use those cells to grow brand new blood vessels in our bioreactor system. The bioreactor system takes about 10 weeks in total. We grow up cells, we inject them into the plastic bag, as you see here. And those cells do what they want to do and what they know to do, and that is to create a new vascular tube. That vascular tube grows for approximately 8 to 10 weeks, and at the end of that growth, we have a very robust, mechanically strong, brand new blood vessel that contains the donor's identity. And that would be great if we wanted to implant vessels back into that donor, but we had to come up with a way to make those newly formed vessels lose the donor's identity so that they could be implanted into any patient without the chance of rejection or the need for immunosuppression. We do that by a process called decellularization. At the end of the growth of this new vessel, we expose the tissue to a series of solutions and reagents that disrupt and remove all of the donor cells, leaving behind a protein tube that is made the same as a protein tube in your body, my body, or anybody else in the world, and that tube can be implanted into a new patient and repopulated with the patient's own cells. We make these tubes, or these new blood vessels, in a bioreactor system. We've heard here today in many different talks about the time it takes to make new equipment or to produce a new product. The images you see here of our bioreactor system have been about 10 years in the making, but we can grow within one system 200 blood vessels at a time. Those blood vessels are grown, decellularized, and packaged all in the same unit, and can then be shipped directly for use in the OR or the clinics at the time of patient need. Here you see the HAV, as we call them, human acellular vessels, being unpacked in the operating room, prepared for implant, which is basically opening the package and putting the tube into a pan of saline, and then it's ready for implant without any other preparations. What happens to that protein tube after implant is that the patient's own cells repopulate and make that protein tube part of its native tissue. The tissue that forms over a period of about 4 weeks to about 12 weeks looks the same as your native vasculature. In the far right image is a picture of an HAV that was implanted 12 years before this image was taken, or 12 months, 1 year before this image was taken during a procedure. When the surgeon cut open the HAV, there was so much remodeling and repopulation to create a new native tissue that the tissue bled. So what does this mean for patients? It took us, like I said, 15 years before we started Humacyte, and it took us another 7 years into Humacyte before we were able to gain approval from FDA to begin our first trial. What you see in this picture is the first HAV going into a patient at Duke University on June 6th, 2013. Here's a picture of the HAV in the patient's arm before the patient was closed. Here's a picture of the patient's arm 18 months after implant and still receiving dialysis through the HAV conduit we put in. To date, we have over 450 patient years of exposure. There's a little over 300 patients who currently have the HAV and are using it for dialysis. And the HAV has received over 50,000 cannulation or dialysis sessions. Why does the HAV work so much better? Why did we want to create a biological conduit? We felt that providing the patient with something that would become part of their own vasculature and be very much like their own tissue would mean better success for the patient and allow the patient to have a longer time to use that conduit for dialysis. And how this happens is by the patient's own cells crawling into that scaffold or that protein tube we implant into them and making it part of their own. Here you see two images. On the left, there are smooth muscle cells that crawl into the full thickness of the tissue and throughout the entire length of the protein tube implanted, as well as an endothelial lining that is created and is continuous through the entire length of the HAV. One other phenomenon that makes us truly different than what else is out there and allowed Humacyte to be the first organization that actually showed that we could produce a regenerative product, a product that regenerates to become part of the patient's own self, is that when the patients are cannulated for dialysis, those cannulation tracts over time heal. And they heal because the patient's own cells crawl in, heal the tissue, and then we don't get any scarring or calcification or breakdown. Much different than a synthetic or PTFE piece of plastic that causes puncture wounds that don't heal and lead to failure. In May of 2016, we published our phase 2 clinical study data. Later that same month, we started our phase 3 clinical studies. We are now about 6 months away from having those studies completed and being able to go through the next steps with the FDA. What we saw in our phase 1/2 studies that were reported in May of 2016 is that our enduring or secondary patency was much better than literature values for PTFE or other plastic types of grafts. Patients out 24 months were still using their HAV. We have patients who are over 7.5 years out with an HAV that still have primary patency. Many of those, 77%, had secondary patency at 24 months or 2 years. As I said in the beginning, Humacyte was founded in late 2004, early 2005, and we are just now here at this point, waiting for phase 3 clinical data. It'll be another probably 2 years until FDA will grant us approval once we file our BLA. But I think we'll be able to then provide patients with an option that may exceed what's currently out there with plastic and other types of PTFE grafts. As I mentioned earlier, what we make are blood vessels, vessels that can be used for various vascular applications. Dialysis access was our first endeavor into clinical studies and using the product in a clinical setting. And since then, we've moved into multiple other areas for clinical use. We have clinical studies looking at trauma, PAD, and now even a pediatric study. And one of the things that we're most proud of is our work with the DoD. We were approached in 2011 by the head of vascular trauma at Walter Reed, who wanted to use our product in patients and soldiers in the battlefield. And so we've gone through quite a bit of work with them to prove that the product we have can also work in a trauma setting, and hope to start clinical trials with DoD very shortly. So in summary today, we've heard a lot about innovation and moving things forward in a positive way in all different levels of dialysis care. I want to commend the champions who are here today and the patients who expect more, because you deserve more, and we need to bring you more. We've also heard it takes a village, and that's definitely true. These technologies, these new policies, they don't happen without pushing and without people putting their time and effort in. And so I want to thank everyone here today for doing that and for the opportunity to talk to you about Humacyte. Thank you.
Good afternoon, everyone. I'm Ikenna Okezie from Somatus, and it's been said already, but I want to recognize and just thank our good friends at GW, Dr. Dominic Raj and AAKP, Mr. Knight and Dr. Collins and Mr. Conway for inviting Somatus and for convening this really important event. I also have the benefit of having one of our medical directors here, Dr. Ehsan Nobak, so I want to thank you for being such a great leader for Somatus. So before I get started, I will admit that I have a cold. I have 3 young children under the age of 5 at home, and 2 of them are sick. And so, but they're so cute that you don't want to quarantine them or wear PPE, so ergo, I've got a cold. So hopefully you can understand me, and hopefully I can figure out, as others have, without turning this off. Okay, there we go. So I don't have a slide on a description of Somatus, but Somatus is a value-based kidney care company. We're based in Tysons Corner, Virginia, about 25 minutes from here. We are early stage. We started in 2016. In 2017, we only had 3 people in the company. We now have a little over 120 people. We've raised over $26 million, all on the notion of, can we innovate when it comes to service delivery for patients with both ESRD and CKD? And what that means to us, and I'll talk about it in a moment, is can we fill in all the gaps in care that tend to exist for dialysis patients and for CKD patients? So I thought I'd start with this slide that this talks about sort of in the beginning when there weren't a lot of dialysis patients, and if you were sitting in the Goshawk Committee, Dr. Goshawk from 1967, where they made a recommendation that Medicare cover ESRD, you would have heard talks about, well, there are not going to be that many patients, and there are only 1,000 ESRD patients, less than that, in fact, in 1967. And not only that, it was only for patients who were less than 54 and were considered medically suitable for having a dialysis artificial machine for them. And at the time, it was thought only 1 in 5 ESRD patients would be medically suitable, meaning that they wouldn't have advanced conditions, chronic conditions such as cardiovascular disease. And so they projected that it would be roughly 40 per 1 million patients who would need dialysis. And today we know that's very different. It's over 2,100 patients per million that are actually on dialysis. So in 1972, there were still as few as less than 10,000 patients on dialysis. Now, fast forward to today, we know there are over 700,000 patients with ESRD, and that number is only growing. So we have projections that we pulled from various studies that show that it'll go up to about 1.2 billion patients on ESRD by 2030. In 2016, ESRD patients, I think we've seen this earlier today, represent less than 1% of patients, but cost over 7% of the Medicare budget. And that number is not going down because the costs for ESRD are going up faster than the overall GDP, or the overall spend, for healthcare. So in the next several years, it'll go up to about 7.6%. So it's just something to watch. It's really a system that we're spending an incredible amount of money on. We've talked about how this is a broken system before, and today, and I just wanted to put some of the quotes up and some of the research that we've seen out there. So CMS, you've heard a lot about what Adam Bowler and Seema Verma are doing at CMS. We're looking forward to an announcement that we think they'll make soon regarding putting out programs that incentivize care to be done earlier for chronic kidney disease patients, to incentivize, disproportionately provide incentives for peritoneal dialysis and transplantation. And so we're looking forward to that. We noticed the JAMA article recently that we thought just pointed out a really important point, that private patients or private pay patients or commercial patients pay a multiple of what Medicare does for dialysis, for the very same dialysis treatment. We think that's evidence of a broken system. The GAO produced a report several years ago that showed that large dialysis organizations may have a perverse incentive or a disincentive to put more patients on home dialysis. We pay attention to all of those things as we build this experiment at Somatus, which is how do you design a better healthcare system for patients with CKD and ESRD. We also noticed that CMS was going to award 3 seats to the Virtual Research Data Center last year. So Somatus applied, and we were given one of them. And the other ones went to, I believe, Harvard and Brown University. So we're excited, actually, that we get to participate in this research study, and we're doing it with GW, where we're looking at disparities in care using Medicare's longitudinal database from 1999 to 2017. So all evidence of a broken system, but there's signs that we can fix it. So one of the first things that Somatus has done is we partnered with a health plan that had roughly 350 ESRD patients across an entire state in their Medicare Advantage program. And we went around the state and tried to figure out what are the gaps that exist in care for all of those patients, and how could we go and fix them. And so I put up on this screen, this slide, some of the gaps that tend to exist. So there are gaps in who's taking care of a skin ulcer, in skin and wound care in general. There are a ton of gaps when it comes to travel and transportation. Many dialysis patients can't afford to get themselves to and from their dialysis treatments, at least not on a consistent basis. And so there are ways that we can step in and help. And we'll do things from as simple as we'll arrange for transportation to we'll even pay for transportation for patients who can't afford it. Or we'll find ways for patients to be funded so that they can pay for transportation themselves. We pay a lot of attention to the quality gaps that exist. So many dialysis patients are not getting the primary care that they would or could be getting. So things like breast cancer screenings or colorectal cancer screenings, diabetic retinopathy screenings, we're doing all of that just to make sure that those things are not falling through the cracks for patients. Transplant, it's been talked about here so much. We care about it so much that we've dedicated a person for the patient to make sure that if there are any gaps in the transplant process, to make sure that all of their labs are done appropriately, to make sure that they're not getting, one thing that we learned today is not getting diagnostics tests done if they're asymptomatic. So there are many things that we can do on transplant, and we take it seriously, so we dedicate some transplant people for that. Medications, we spend time inside patients' homes, And we will literally take all their medications, empty them out on the kitchen counters, and say, this is great, this is what you should be on, this is your physician's prescriptions, and these ones you probably shouldn't be on, or you should have stopped it 6 months ago. And so we'll do that every time we're interacting with patients, and we'll spend a lot of time in their homes. We'll spend anywhere from 45 minutes to 3 hours in a patient's home, just going through health risk assessments and figuring out how can we close the gaps that exist in their care. Dialysis access and access. Many patients tell us, especially when they've initiated dialysis, that they did have a conversation with someone about doing peritoneal dialysis or home hemodialysis, but it was a short 15-minute conversation and they couldn't quite process everything at the time. So when we're there in the patient's home, we're there for a while. And we're there with their caregiver, and we're talking about PD, we're talking about HHD. And they get to ask questions that they didn't think about when they were sitting in front of the physician or the nurse. So it's really helpful to have that one-on-one, or often it's usually we're sending 2 or 3 people into the patient's home interaction for a long period of time in their home. Housing and home support, nutrition and food, the list goes on, and it's just exciting that we get to work with patients in this way. And so as we were doing this experiment, which is spending time in the patient's home to figure out what are the gaps that exist that we can close, we decided that we had to start with data. So we'll go to a health plan, for example, or a health system and say, give us all the claims data that you have on your patient population. And we'll collect data from health information exchanges. We'll take clinical data from EMRs. We have a care management application that serves as the one common platform where we can integrate all the data that's out there, including social determinants of health data, to figure out what's the appropriate risk stratification for this patient. And we try to keep it simple. So they're either high-risk ESRD, they're rising risk, or they're low-risk ESRD. But based on that risk profile, it dictates a certain amount of resources and a cadence of those resources to be delivered to the patient in their home or in the hospital or wherever they may be in a SNF. And on the bottom left of this slide, you'll see that there's, it's a little hard to read, but for every stage of CKD and for ESRD, we have layered programs that basically are, for each patient, they're either high risk, rising risk, or low risk if they're ESRD, but then if they're a CKD patient, there are about 5 different categories of risk inside the CKD stages. And based on those stages, we'll give them a health coaching program, a wellness program, a renal replacement program. We'll talk about transplant options preemptively, and we'll try to get them ready throughout every stage so that they're essentially as in control as possible with the disease process. And then we have a multidisciplinary care team that includes social worker, a renal social worker, a renal dietitian, a renal pharmacist, a renal nurse who serves as the quarterback of that process, and a community health worker. And those folks are going into patients' homes. Now, when we first started this in January, we had the concern that patients wouldn't want us in their home. So we're these new people, they've never met us. We're working on behalf of the health plan, not even their physician directly. And the health plan did us a huge favor in that they, together with Somatus, they co-branded material that went out to the patients, went out to their nephrologists, went out to their primary care physicians and all the hospitals, saying you're now being invited to participate in this new program that will bring you extra resources. So we were concerned originally that, well, maybe patients aren't going to want us to come into their homes, but as it turns out, they did. And the biggest question that we got was, is this really a free service? And it is a free service. So it's a covered benefit from their health plan. And you know, they still question that, like, do we owe you something? So the other day, we gave a patient vouchers for, I think, 6 months of dialysis treatments to transport back and forth, back and forth. And so we're paying for Ubers and Lyft rides and all of those things because it's better to have the patient spend $30 round trip to go get their dialysis treatment than to miss a treatment and go into the ER and be admitted for a $500 dialysis treatment and a $10,000 admission. It's not good for the patient, it's not good for the system. So we have the latitude of doing that because we're under waivers, because we're taking delegated risk from the health plan. So we're essentially a hybrid. We do provide dialysis, we provide home dialysis, but we do this other service that tries to keep patients off of dialysis. This slide gives a little bit more detail on the various programs that we offer. The one thing I'll say about this is I'll give you an example of a patient that I had direct experience with under the complex care coordination program. So this was one of our early visits, and I joined the community health worker and our renal nurse, renal dialysis nurse, in the patient's home. And this gentleman had started dialysis about 4 weeks prior, and fortunately he was starting on a fistula. But his biggest concern was his wife, for whom he was the primary caregiver. And what he was concerned about is because he couldn't get her in and out of the bathtub to take a shower. And so by the time we had arrived, it had been about 2 weeks since she had had a shower. And both he and his grandson were saying, she's smelling, it's not great for her. And the last time he had tried to get her into the bathtub, he spiked his systolic blood pressure to 220 and went to the ER. And so it's a huge stressor for him. So we said, well, look, we'll try to figure out something here. So I and the dialysis nurse and his grandson walked into the bathroom, measured the bathtub from the ground to the lip, and it was 21 inches. And in a few moments, we looked up on an iPad or an iPhone a bath chair that had different levels. So it can be at one level on the outside of the bathtub and a different level for the inside of the bathtub. And the reason, by the way, his bathtub was so high for him is he had raised it a couple years earlier for cosmetic reasons. He thought it would look better. So now it presented this challenge. So we found on the phone a $55 bath chair that you can sit on it on the outside and just sort of shimmy till you get into the middle of the bathroom, and then his wife can take the shower that way. So it took a lot of pressure off of him. So we helped him get this $55 chair and removed a huge stressor for him. So we call that, it's like a social determinant of health, but it's basically just do whatever is necessary to help the patient get through the day. And so that's the experiment that we're running, and these are some of our results. So we started that program. It's a statewide agreement in Tennessee, and we started that program January. In February, we now have 2 months of data, and what typically happens with claims data is you have to wait for all the claims to sort of run out and make sure you've captured everything. So now we're looking at February 2019 data compared to 2018 full year average. And the utilization in terms of inpatient admissions has gone down significantly, 14% per 1,000, 24% reduction in inpatient surgical admits. You can see some of the other metrics there on utilization. And then on cost, if you look at the overall cost, it's gone down 10%. Now, that 10% reduction was our full year target for the cohort. So we wanted to make sure that we drop costs 10%. If you look at the comprehensive ESRD model, the ESCO model, the average for the first performance year was between 5 and 6%. So we're off to a strong start here, and we think it's because we're just spending time figuring out what's good for the patient. I'll close with a few pictures, which these I assure you are HIPAA compliant and with consent from the patient. So this is an example of, we try to focus on, again, Somatus was founded on this notion that we can fill in the gaps in care that exist for both CKD and ESRD patients. So this is an example of a gap that happened for a recent start dialysis patient who, soon after he started dialysis, he noticed that he had all of these sores on his body. So they're bullous looking, they're red, they're raised, and some of them are not, they're papules, but they hurt, and they just look awful. And he asked his nephrologist, what should we do? And the nephrologist said, you got to call a dermatologist. So he called a dermatologist, and the dermatologist couldn't see him for 30 days. So when we went into the home, it was probably day 3 or 4, somewhere in that neighborhood from when he started seeing the lesions. And he told our nurse and our community health worker, I am calling 911, and I'm going to the ER now, and I'm not leaving the hospital until someone tells me what these are. Okay. And we said, well, just wait. Let us do that on your behalf. So our nurses called and called until they got a dermatologist that would see him the next day. And so he agreed, I'm not going to the hospital yet, I'm gonna go straight to the dermatologist. He got a biopsy. Turned out this was an allergic reaction to the dialyzer membrane, and no one had picked it up. So we told the dialysis center, this is an allergic reaction to the dialyzer membrane. We've got to get a biocompatible membrane or something different, and they did. They switched the membrane, and over a course of steroids, this went away, and it didn't take long. So we have an after picture of him now, and he's fine. But it's just an example of, in this case, to do the right thing, you have to have time, right? So you got to have time with the patient, and you have to have, in this case, nurses that were really aggressive to figure out how do we get that dermatologist visit. And that's one thing that if we had more time, we'd be talking about the culture, the type of people that you need to have on board. And for us, it's nurses that when they see this, they don't take no for an answer. They're running through walls, and they're super aggressive and even borderline obnoxious. But that's what you need in order to drive change for patients. Thank you.
I'm gonna just use this and stand over here, otherwise you're just gonna see my head. I'm a little different than our other panelists. I don't work for a company or anything that works to improve dialysis. Rather, I've lived it my whole life. I was first diagnosed with kidney disease back in 1988, and I was only 6 years old. Since then, I've had to learn a lot of things on my own. Some things were taught to me, but especially in the 90s, so much I had to figure out for myself along the way. At first, we tried transplanting me because I was a kid and we wanted to give me the best chance I had, but my disease is very recurrent, so after 3 transplants, I knew already by then, before my doctor even told me, we needed to hold off on a 4th until we could make sure that it would stick. So I started dialysis in high school. That began my phase of trying to learn how to manage life and dialysis, and thankfully I was such an overachiever before then that I only had to worry about going to school 2 days a week. So I would go to dialysis 3 times like most people, go to school the other days, and I still managed to graduate with my peers. When I went into college, this became more difficult. At first, it was still the same thing, 2 days a week, and you can't really get a 4-year degree done on 2 days a week. So for the first 2 years, which took 4 years actually, I still did in-center hemodialysis. During this time, I was just getting used to dialysis. I was learning the diet, so I was more accustomed to it, and just making it a part of my life as best I can, which isn't easy when you're late teens, early 20s. But then after a while, I had had so many abdominal surgeries as a kid, that's why we didn't consider PD or anything else back then. But after I'd been surgery-free for several years, my doctor said, let's try PD. And we did, and it worked. From that point on, I was able to do my dialysis on my own, live on my own, and even go to school full-time. That's one of the best things I could tell any patient if you want to have control of your own life and manage your life and not let dialysis dictate it, is to start some home therapy, because then you choose when you're doing dialysis instead of it choosing it for you. I was able to keep doing PD throughout the rest of my college career, which even with all kinds of unexpected health things that came up, any number of random things that would put me in the hospital again, I still was able to graduate, although it took 10 years, but PD got me through that. Then after that, I wanted to work full-time or work part-time, but at least have a job and do something with my life thanks to my college career. But PD was starting to fail me at this point. Now I was faced with, what am I gonna do if I wanna do that? Because there was one summer where I did dialysis, a job, and went to school, and that is not something anyone should ever have to do. So I immediately told my doctor when PD was no longer working for me, can I try home hemo? And I'm so blessed that I have a doctor that's very supportive of me, because he did everything he could to help me get a fistula right away and get me into training. So I was only back in center for a few months before I went back on home hemo. And it made such a huge difference. Once again, I was more in control of things, and I was able to work a job. And I would actually do my dialysis in the afternoons, and then sometimes go to work either after if I had a night job, or vice versa. If I worked during the day, then do my dialysis at night. But it gave me flexibility and control of my life, and that's just how you can manage your life and make it work around dialysis for you by doing home therapies. The other things I've learned through all of this as I've been more independent and done more on my own, and especially living on my own, is I've not just learned my diet, but I've learned different things that make a difference. Like if you do in-center versus home therapies, you don't always get a choice in your environment. One thing I hated about the in-center treatments was the temperature was always really cold. I was always assigned a chair, and I really didn't have control of anything in the room. But at home, it's my house. I have my own chair that's just for what I use, and no one ever sits in it but me. I'm able to control my thermostat, which when you've got your blood out of your body and you're already anemic, that makes a huge difference. And I don't have to worry about alarms going off or other patients that might be making noises because they're having a hard time. It's all focused around me. And it's a good morale booster because then you don't feel as depressed as if you're on the in-center. I also have learned that with doing the home therapy with my fistula, I said from the beginning, I wasn't gonna let any of my care partners take care of things for me other than the bare minimum. I learned to cannulate myself. I manage the treatments myself. They help me with like the numbers that we take down during treatment, and they help me with things I need a third hand for. But I do everything on my own. I set it up, I cannulate myself, I hook up, and I then run the treatment. And when they need to, I can take care of myself while they're doing other things. I only need that extra safety or support during my treatment. So I've become in totally charge of that as well. Ultimately, through these different things, I've learned the more I take on, it's a lot more responsibility, but I have more say in it. It impacts my life a lot less than it would if I had to stick to a schedule that somebody gave me or come at a certain time when I'm told. And it's just, the morale component makes a big difference when you're already having your health diminish because you need renal replacement therapy. Overall, this is what I try to tell patients, is speak up more. Don't wait for options to be given to you. Find out what you want, find out what's best for you, and tell your doctors or your nurses, this is what I need to work for me so that you can make it work the best way that you need it. Through that, I mean, like I said, I went through college, and it's something, it's hard to say out loud compared to actually living it. But it's the best way I know to manage your life in dialysis, is just do all of it yourself. And I think I also mentioned earlier, I learned my diet, and I'm kind of running out of things to say. It's just, you really have to just get on top of it. And I wish there were more people that would advocate for patients besides themselves. But if there are more people that are asking their own questions, then we'll have more patients that are healthier like I've been and able to do things like I've been able to do.
I'm gonna turn it over to Dr. Collins, but in a second, sir.
Wow, what I just heard is amazing. For the first time in my life, such a person is just amazing.
Well, actually, you took the words out of my mouth,
Yep.
because Brian says that, but you know, when we're on Capitol Hill, Brian's there. He calls me up, Rich, what can I do?
Yeah.
I mean, this guy's amazing, really. Yeah. We're so glad he's here and part of AAKP. He's what we're all about.
Yeah.
Go ahead, Dr. Collins.
And so, once again, Brian, thank you so much for your powerful story. Hopefully our audience is taking that and internalized, and they'll be able to use that to help their patients as well. Thanks so much to Rich, Rebecca, Juliana, and Ikenna. I want to first start with a question about transitional care programs. And really, when you think about how siloed our society in dialysis is, what is your approach when it comes to looking at patients who haven't been fully educated on all three modalities? And what do you do regarding incorporating more nephrologists who maybe have never even heard of a transitional care model until today?
Well, we start this in CKD clinic. We are very proactive about having the patients speak with our own nurse practitioners who do CKD education, but also we send them to the education provided by the dialysis companies, whichever area of the state that they live in. And when the patients come back to us after having the education, we talk to them about it. Basically, it's communicating and discussing with them what they thought. I mean, nobody comes back to us and says, "Oh, I can't wait to do that," you know. But they, you know, they feel better usually about it. And the transitional care unit often we use for people that didn't have that education prior, but landed in the hospital with acute kidney injury and started dialysis, and they are basically not thought to be likely to recover. And you know, all of our nephrologists we have 10 nurse practitioners and 10 nephrologists. They all know about this program, and when the patients are in the hospital, they talk to them about it. So, you know, I don't have a lot of other nephrologists in the area to tell about this program to. So, does that answer your question? Okay.
Yeah, and then I'll second that to Ikenna regarding the fact that there's so many units in this country that don't even have all three modalities. I think we all find that as a challenge. I work primarily in wards 7 and 8 in DC, and there are no home units on that entire side of the city. So when we have I know. So when we have those patients, what strategies do you have to maybe improve their access to home suitable dialysis?
Wow, that's a challenge because DC is one of the 12 states that are certificate of need states, and it's hard to put in a unit. So that's one of the reasons why there's not enough PD and HHD in DC. I think it's hard because you do have to, in DC, you would have to have the state health planning authority to approve the placement of a PD and HHD program. And so as much as we'd want to go into an environment like that and say, well, we'll educate a patient and we'll do a home-based PD program where we will certify their home as the training site, we wouldn't be able to in that case. So we'd have to focus more on transplant options and making sure that the patient has a fistula or a graft, or going across the border, so to Virginia or to Maryland, which are not CON states. And so as long as the patient's willing to travel a little bit of a distance, we could put a PD or HHC program just outside the border.
If I could add to that, and West Virginia is a CON state as well, and several years ago when there were some, shall we say, there was some competition about putting dialysis units in various places, you know, the CON authority came to us and asked us to talk to them about why, you know, what type of requirements there should be as far as like distance. Can you have a unit 30 miles from another unit or what have you? And what we suggested to them was, you know, make the home units not have to go through the CON. So in West Virginia, you can put a home unit anywhere, but you can't put an in-center unit anywhere. So that helps by separating those out, and that was one thing that we were able to achieve with the help of the CON.
Thank you.
I have a question for Dr. Okezie. Is that the right way to say the name? I think it's inspired by my personal experience. I now live in rural Tennessee, but I'm originally from Italy. I train in a very different healthcare system, where many of the activities that you guys were describing as innovative, because of just a different system in which healthcare is delivered, are just part of the standard of care. So, for example, home visits are just part of the standard of care. Did I understand correctly that you guys have partnered with a health care provider or basically an insurance company?
Yes, that's correct.
And so my question is, how can we leverage what you are finding in a subset of patients that in rural Tennessee is only a subset? There are tons of patients who are uninsured or on Medicaid or eventually on Medicare. How can we leverage the findings that you have to then really lead to what we were discussing earlier this morning, which is to change the payment system? Because right now, those findings are amazing, and they only apply to a selected group of patients who also have, obviously, other reasons than means to experience better health outcomes.
Yeah, thank you for the question. So, and we have offered to KidneyX, to HHS, to CMMI, that we would, if we do a good job, which so far we're doing a good job, but it's only 2 months in of data, that we would try to do a study on the interventions that we're doing and which ones are having more impact other than others versus others. And to be totally honest, we're not really sure where the biggest impact is. We're just doing it all, right? And then we're going back and we're studying and trying to figure out through some regression analyses which ones really did have the biggest impact. But we're making them all available, sort of like an open source model, because we don't believe that it's the individual act of each of those programs that I put up. It's the team, and it's a collective impact, and it's a culture of ensuring that you do whatever it takes to get the patient as healthy as possible.
Yeah, I could not agree more. In fact, I was not thinking so much of teasing out which specific program, but demonstrating the savings that one can have in such a system where you're actually preventing admissions, preventing a number of very expensive interventions by maybe being able to buy a $55 chair.
Well, also commercially, we are taking that model to a number of different states. So next year, it won't just be Tennessee. It'll be a few other states, thankfully.
Thank you for coming to Tennessee.
Thank you.
My next question is for Dr. Blum. Is the idea regarding the HAV that the patient's native vascular smooth muscle cells, they migrate to the HAV, and that helps allow for that original vasoconstriction that would occur when the needle first comes out? And that can that result in an improved cosmetic appearance like downstream?
Right. So you saw the image of the gentleman who was 18 months out. His conduit looked almost identical as to the day it was put in. You didn't have the bulging and the aneurysm look and the bruising. Hemostasis occurs almost the same way in the HAV as it does with PTFE, except that the patient's own cells can go in and heal that cannulation or that tract mark naturally.
Thank you. All right. It's time. Thank you very much.